I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in.
When I read.
Oh, sorry.
All right.
We're going to pause it. Hello, my loves, and welcome back to the Love and Science podcast. I am so excited about the conversation we're about to have today. I have Dr. Yemi Famuyiwa. She is a beautiful, beautiful friend, and she is a beautiful REI. I was thinking about it. I don't think I've had another fertility specialist on Love and Science podcast yet. And what we're going to talk about tonight is a whole host of things, but one of my favorites is personalized care. So before we get into that conversation, I want to formally introduce Dr. Yemi. She is a board-certified reproductive endocrinologist and the founder and medical director of Montgomery Fertility Center in Rockville, Maryland. She completed her fellowship in REI at the NIH, and she also serves as an associate clinical professor at George Washington University. She's the author of the forthcoming book, The Quest for Fertility, and she's also the host of the Fertile Talks podcast, where she bridges clinical insights with empowering fertility education. She is a frequent media guest and thought leader, and she's currently developing the Fertility Blueprint, a concierge program that applies precision medicine, systems biology, and exposomic analysis to reproductive health. This is what the world needs. So Dr. Yemi, it is so wonderful that you're here. Thanks so much for being on my podcast.
Thank you so much for having me, Erica. It's a pleasure.
Yes. All right. So let's first talk about your journey. Did you always want to be a fertility specialist?
No, I knew I always wanted to be a doctor from age 9 because I just love interacting with people. I'm one of those very empathic people that I like to help people in pain and solve problems. So my first goal was just narrow tunnel vision into being a physician. And then in medical school, I was one of those students that kind of had an affinity for every specialty. So when I narrowed it down to what did I have fun doing, because I trained at Emory and we used to go to Grady Memorial Hospital. I don't know if you've heard of Grady.
Yes, I have. Very
It's
busy.
probably maybe Cook County Hospital times 4, if you will. One of the largest of its kind. Maybe Parkland Memorial is busier, right? I'm talking those kind of huge inner city hospitals. And we, as students, there was just so much volume that as a student, I got to do like 20 deliveries of my own. And that um, time of just being there when a child is being birthed, there's something so magical about it that you never quite get used to.
Mm-hmm.
So when I looked around and I said, what do I truly enjoy the most? And, the light bulb just clicked. And I knew I wanted to go into OBGYN. I loved it. I love deliveries. I love the physiology of it, studying and helping women. And it was in residency that I really found I actually liked the why of it more, like the science behind it, the physiology behind it. So I was always like doing deep dives into articles explaining, like, well, let's talk about meiosis a little more. Let's go a little deeper than just simple biology. So I went into a fellowship in that. And while at NIH, I was doing a lot of research, publishing. I mean, as a fellow, I got like 13 publications and co-authored
Whoa.
some books. Um, and that was back when we had to actually have a published thesis. I
Yeah,
think now they don't have to be published.
they don't. I was in that era as well. Yes. No,
Yeah.
it's gone.
So
Yeah.
I had so many publications by the time I went to defend my oral boards. Um, but one thing that I kept drawing me back was I really, truly liked just interacting with patients. And after 5 years of being at the NIH, one day I said, you know what, I think I like patient care a little bit, just a little bit more than the research part. And that was the turning point for me to say, hey, I want to go into private practice and really focus on my patients and not so much on bench basic science research.
Wow, that's so amazing. And I don't think I quite knew the extent of your journey, and that's just like so wonderful to hear. So tell me now, so how long have you been in your private practice now?
Started opening it 98, fully 1999. Yeah,
Yeah, so it's been a while now, right?
it's been a
And
little minute.
yeah. So tell me some of your favorite parts of your job right now as a fertility specialist.
I think, well, favorite always is when people bring down back their babies when they have, or do that initial ultrasound and you hear a heartbeat, right? Or like, you go in a public event and all of a sudden you see someone calling you and go, Dr. Yemi, do you remember? And, there's this full-grown adult, that's the baby you helped create, right? So that's always rewarding and fulfilling. Um, from a physician staff, scientific standpoint, and I'm sure you probably noticed this, when I'm doing procedures, I totally get into a state of flow. Do you
Mhm.
notice that? Like
Yeah.
I totally zone into that total needle point, that hysteroscopic narrow vision point, and I can totally tune the entire universe out.
Mm.
It's easy for me to fall into that flow. It's the same thing if I'm studying. I can totally do a deep dive into any topic I'm on. And when you hit that flow state where everything, just disappears, where you really narrow in. So that's a different kind of enjoyment from, seeing patients
Mm.
bring their babies. And then also just talking to people. Like, I have patients that come from all over the world. So, I'll talk to my patients from Pakistan, from India, from Mexico, from Africa, from Canada. I have patients from Ukraine and from
Mhm.
Russia, right? I have some from London. And I find patients and human beings so fascinating. I like to hear a little bit of their background, a little bit of their story, and it's so engaging.
Oh, that's so beautiful. So tell me, what do you think sets you apart? Obviously, if somebody's coming from London or Afghanistan or Pakistan, like there's something about the way that you are in the room that draws people in. Are you aware of what that is? Like, can you articulate what that might be? I will say you're
Yeah.
doing a lot of innovative things in your practice, and we can talk about that too. But what do you
Yeah.
think is the draw
So
for these
I
international patients?
think the draw is they hear that patients engage with me, right? So I take the time to hear them out, to really brainstorm a treatment plan that's unique for them, right?
Mm,
I might see a patients who've been through two, three treatment cycles elsewhere, and you don't want to do the same old, same old. You want to really go into, okay, what's going on here? And what can I do different? Or someone who's starting the journey for the first time and you want to hear their story. Now, that being said, I'm probably not going to connect with every single person, but I think the ones that I do connect with, I believe that's part of what the connection, and it's a two-way street, because I think when you can really listen and show some respect for your patient and truly appreciate them, right? They also can feel that, right?
hmm
When you it's like a soul bonding, just listening to the patient and hearing their story and trying to figure out their source of pain. Now I do say, like I said, you're not going to connect with every single person, but then that's why there are different practices. right?
That's right. And I think that, I mean, what I hear from, and most of my listeners are female physicians, some female professionals within fertility, that our fertility care has become like a factory, where
Yes,
everybody's just a number and their doctor, doesn't get to communicate with them very often. And I don't think it's because that I think most REIs want to do a good job, but I think the constraints of our systems make it harder and harder to have that soul-based connection. And so,
yes,
you by branching out on your own, which is, I mean, you're an entrepreneur, like that is its own whole thing, running an office staff and all everything that's
yes.
involved in that.
Mhm.
So that is its own labor of love. And I believe that one of the reasons you do that is so that you can be innovative, so that you can have these connections with your patients, because people want to be heard, they want to be seen, they
Right,
want to
right,
know
right.
that you know the details of their care and that you uniquely care about them and their journey. And I think a lot of that is getting lost, in this day and
Yeah,
age, this day and
yeah.
age.
And
Yeah.
and I think you and I talked about this earlier. You want to care for your patients, but first you have to care for yourself because if you don't fill your tank up, there's nothing left to give. So I needed to be in a work environment that was um, mentally sustaining me, that was fulfilling for me, and emotionally supportive for me. Yes, everything has its stresses, but if I can eliminate the stresses that are extraneous, um, as much as I can, and then use the rest of what I have to really hone down and focus on what I'm doing. It's not an easy road, but when I started, that was my main focus. And over the years, that has continued to build and feed up on itself. And it's rewarding to go, wow, yeah, this is why I'm doing this. This is working. And
Mm-hmm.
I can see a difference in people's lives that I'm making. So that in itself is it fills your tank and go, I got it. I know why I do this, and this is
Mm-hmm.
the result. Yay, let me do some more.
Oh, that's so beautiful. It's like this positive feedback loop, if you will.
Yes, yes, it
So,
is.
so I'd love to talk about some of the innovative things that you're doing in your practice, because I'll tell you, I have some patients, I'm at an academic center where, it's a wonderful place. Although at the same time, sometimes it's a little bit harder to bring in some of the newer things or things that, maybe don't have a lot of, RCT data behind them and such. And so can you speak a little bit about some of the innovations you've brought into your practice over the last, say, 5 years, and maybe even things that you're considering that are showing some promise?
Yeah, so I have explored using PRP in very select patients. And I tell patients it's not for everyone. And like you said, the RCTs may not fully show a full benefit, but there are some individual studies coming out saying that they're seeing some effects. And then you're looking at how was it done in those studies compared to what's done in the US. And the biggest thing is the PRP preparation technique is so widely variable and different across platforms. So if you're not using a platform that really concentrates that PRP to a very high concentration level, then you may be getting some of those results that may not be as good. But also picking the right patients and not letting the patients become deluded. And I tell them this is still considered experimental,
Mm-hmm.
right? So it's not for everybody. It's not for a 49-year-old or 47-year-old who thinks, oh, yeah, I'm going to wake up all my eggs that are there. No, I think it's someone who's like in their late 30s, whose reserve is rapidly declining,
Mm-hmm.
right? Someone, um, maybe they have one or two follicles left and they're not responding. I've seen those patients respond with a few more eggs, and a few more better quality eggs. Now, time will tell whether your success rate is going to be yay higher compared to the similar patients. You can't compare apples and oranges to similar patients who don't do that, because those patients, when you can't get anything from them, then they have to go the donor route. right?
Mhm.
So it's not for everybody. I've tried it in a few, still looking at it. Um, and then I was at ASRM. I happened to talk to the scientist whose lab director was my lab supervisor as a physician when I was at NIH. And he now runs two big fertility centers in China where they do over 2,500 cycles. And they were telling me they do over 1,000 PRP cycles. And I'm like,
Mm.
okay, what are you doing that I'm not doing? And they were like, well, have you tried using that needle or injecting with this technique? Or so just different nuances of how to use it. I said, interesting. I didn't think about it that way. Um, or for instance, using I'm going to try and get when we were fellows, we used to use of course sterilized, the colonoscopy,
Yeah.
sigmoidoscopy, right?
Yeah.
We would use that for hysteroscopies and they worked fine. You know why? Because you could turn the head in any direction and got a 360 view, right? Versus your rigid hysteroscopes.
Right.
So one of the things I'm looking now is to get, there are now neurosurgical scopes that they use to do pituitary surgery through the nose. Very fine, but flexible and can wend their way, and you won't need anesthesia. So just one of
That's
the few
amazing.
things I'm looking at getting in the office.
And there are those operative?
Some of them are, you could do
Yeah.
minor biopsies.
When I was
But
a
if
fellow, we
that,
had a, go ahead, go ahead.
no, go ahead, tell me, I want to hear.
I was just going to say we had a 3 millimeter diagnostic scope in our office when I was a fellow, and it was diagnostic, right? Not operative, but it was so great because we really could see up and around the corners in a way that we could not even in the OR. Yeah,
Yeah. Was it flexible?
it was.
Oh, cool.
Yeah.
Awesome. Yeah, when you use a flexible scope, it's very hard to go
It
back to
is
a
so hard
scope.
to go back. And I think a lot of our listeners will resonate with that, right? Um,
Yeah.
are you doing any intrauterine PRP at this time? I feel like that's another topic of
Yes.
interest.
I did a few and I didn't see as much. I think I saw one patient who had not gotten pregnant at the different centers with multiple times. So I did with her and then she got pregnant, delivered.
Mm,
Then I did a couple after that, didn't see any success. So I was about to back off. And when I was talking to this specialist, the ones from China, and they were going, in select patients, have you considered actually injecting the PRP hysteroscopically into
mm.
the lining in 4 different avenues? So I'm waiting for their data. So that's something I'm going to investigate and see if that's something that may be of benefit. Now, I do say word of caution. You wouldn't use PRP if there's any endometriosis or adenomyosis, right? Because you don't want to stir up inflammation.
Right.
So you need to first rule that out. And if you rule that out, can it work in mundane severe scar tissue formation, um, you know, chronic endometritis that's, not being treated with any technique. So I am going to be looking at that. I haven't done a whole lot of that, and I'm basing it on what I heard from the center.
It's so fascinating. I think, one of the biggest questions out there is like we were talking earlier about this recalcitrant thin lining and how you got to have if you can make good embryos, which some people really struggle with that, but if you can make even one good embryo, how can you really make the environment, the garden, like the soil,
Yes,
how can you
yes,
make it a rich environment for implantation?
yes,
I think we're going to be seeing more and more of these techniques, but I think it takes
yes,
people like you who are doing them, obviously in select patients with
yes,
careful counseling and everything, because like that woman who had her baby, where your first one, like that baby probably would not exist, without
right. The one
you.
that did IVIG that I told you about. Yes,
Yeah, looking at the
yeah,
innovation, looking, sort of pushing beyond what, the limitations of what we're, those of us who did fellowship a long time ago, the science keeps evolving. And I think
right.
unless we're on the forefront of that data, of that science, and like you're actually doing those things in your practice, I think that that's really when we're going to see the best patient outcomes, right? I don't want to
Yeah,
say to a patient, oh, in 2040, we might have some better insights and it's really too bad because you're going to be out of your reproductive window by then. People want answers now, and I think
right.
if we have tools that are potentially available. I tell
Right.
people, go see my friend Dr. Yemi in Maryland. She's going to help you because people travel. We know this. People travel for their
Right.
healthcare all the time, and
Right.
people go to other countries even. And so if we
Yeah.
can,
I mean, people
yeah.
they fly across to Europe and Asia because they're like, I really want to know if this will work for me. Because the alternative is I need to go to donor egg and do surrogate. And you still may need to do donor egg or surrogate, but maybe this might be an attempt you might give, and if it doesn't work, fine, move on, but it might work for you. So, again, like you said, the key word is in select patients. And I always sit down and counsel patients so that they have realistic expectation, right? So, someone whose endometrial lining has been completely stripped, solidly scarred down, nothing's probably going to rebuild that basalace layer. It's gone,
Mm-hmm.
right?
Mm-hmm.
Once it's removed. So I think having realistic expectations and talking to the patient is really key.
Absolutely. One other question I wanted to ask you about is your donor egg bank. I will
Yes.
tell you, I struggle to help people find donors who, look like them, who have similar
Mm.
cultural backgrounds, who, have different characteristics that are important to them, beyond even those characteristics. And so, can you say a little bit about what motivated
Yeah.
you
So,
to get
yeah.
your egg bank and how that's going?
Well, what led me to do it was especially during COVID, when I had patients that needed donor egg and we couldn't find any. Or they will
Mm-hmm.
say, well, we have only one egg from that donor, and then we have two eggs from that donor, and we can combine it with one egg from that donor to make. And people are like, no, I want all my children to have the same genetic material. But they didn't have any choices, right? So it was very distraught for them. That's number one. Number two, sometimes patients were coming to me and saying, well, I put my name down at XYZ donor bank, and I'm told I need to wait 8 months to find someone like me.
Mm.
So then I said, okay, clearly there is a need, especially for my patients, to better help them. So that's when we launched the donor egg program, selfishly to help our patients. And now we're opening it up to other people to help them find exactly who they want. Like, you know, people might think, oh, yeah, that patient's African, just get her an African donor. Well, they may beg to disagree. They may say, well, yeah, I'm not from Togo, I'm from Ghana, or I'm from Guinea, and I don't want anything to do with the blood from Somalia. There are different nuances, and they want to be picky, right? So we help to curate um, differences like that and entertain that. Even not just I'm using Africa as an example. Someone from Asia, or I had a patient who I think the husband was from Ghana and she was from Greece, and she
Mm.
felt strongly about having genetic material from Greece in in her donor. So we had to look for that ethnic background for her.
Mm-hmm.
And the donor wanted, it was a known, they knew that the identity was disclosed because the donor wanted to know who she was giving her eggs to, and the parents wanted to know who
Mm-hmm.
their eggs were coming from, right? And it was just a match made in heaven for that couple.
Mm. Well, I don't think there's anything selfish about creating an egg donor program because I will tell you, and for any listener who does not know, the amount of paperwork and regulation. I mean, the FDA basically considers this the same as a liver transplant. Any transplant is like
Exactly.
transplanted tissue. And
Yes.
so, the level of regulation and the level of scrutiny and the every single thing has to be, in a row. Even that in and of itself is a huge feat. I remember when I was a fellow, trying to help my diverse patients. I was at the University of Michigan. There were a lot of researchers. People came from all over the world. And I remember like we looked at our typical egg banks that we, and this is like when egg banks were just coming of age, right? I looked at them and then I said, well, I need a little bit more diversity here. And I remember there was one egg bank at the time that marketed themselves as being more diverse. And it was like astronomically more expensive. And I was like, wait a second here. Like we need more options that are going to help people. Like you said, African, absolutely, African descent, also Asian donors, like
Yeah,
there's so many patients, and we know that the data that's done on mostly Caucasian people, that there's genetic differences in receptors, and that our typical FSH doesn't always, track. Like there's so many things that we understand now about genetic variation, even in an IVF stimulation, right? And I
right.
think that, we have to understand that this is a diverse world. We have a diverse patient population. In order to serve our patients, we need to provide donors that,
Right.
look like them. And it's
Exactly.
important. So the
Yeah,
fact that you can offer people with all different backgrounds, egg
yeah,
donors who, are in alignment with how they want their children to look,
yeah,
culturally, ethnically, all those things, I think that's a huge benefit. And so if you
yeah.
don't know that Dr. Yemi is doing this in Maryland, you need to go find her because she's
And
amazing.
we still do all those FDA clearances. We do them. We do them. We have to obey those laws. And that's one of the things like patients tell me they want to go buy eggs um, from a foreign country and bring the eggs. I'm like, you know what? I can't take it. I
Yep.
can't take it because those eggs need to be processed the same way that I would process a donor here, meaning they have to go through the full FDA regulatory clearance.
Yes.
And if you can't show me that your donor has done that, then I can't take those eggs. And
Right.
also, number two, we only accept maybe 4% of the people that apply into our egg bank. I don't know where those eggs are coming from. I don't
Right.
know the medical background, the psychiatric background of where those eggs are. And you don't even know if some of those eggs are coming from women that have been trafficked,
Right.
right? So I'm very, very particular about that. And that's one of the reasons why I do not accept eggs coming from overseas if I don't know the full source of it.
Oh, absolutely. And it's also for the patient's protection. What if that's an
Yes,
HIV positive donor and there's some error in the paperwork? I mean, I think at the end of the day, the regulations are there to protect the patients,
to
to make sure that
protect,
they have
yes,
the best possible outcome. Yeah, it's a lot of headaches, but it's like the TSA. I always say the TSA exists so that we can all step on the airplane safely, right? It's kind of like that. And the service you provide to people is just so amazing. So, what I will say is, Dr. Yemi, can you hear me? Dr. Yemi? Book. So one thing I was also curious about is this book that you've been writing. And I mean, I've
mhm,
had the desire in my heart to write a book for a long time. And it's like,
yes.
where do you start? Like, how do you write the most impactful, book that is authentic to you? So can you tell me a little bit about what your book is about and why you decided to have the focus that you do?
So my book is based on patient stories to explain the science and to show how people went through what they went through, what they did to overcome it, with the thought that if people can hear and see their own stories in this book, they can go, oh, wow, this gives me hope, and this is what they did. So I'm teaching the science of reproduction from the point of view of patients' stories. And that's what led me to write this book.
Oh, that's so beautiful. So this is your lived experience, right? And the
Yes,
people that you've helped and,
yes,
all your scientific background, you
yes,
could go from the science to the patient, but you actually start from the perspective of the patient
exactly.
and
And then
then
go
draw
to the
people in
science.
that way. Oh, that's so
Yes,
beautiful. Is
yes.
there is there one vignette that particularly comes to mind when you think about this book that you're writing?
Mm. So I think there's so many. One of the ones that's most powerful is I had a patient who and I think I've recounted this, who was caught in the Sierra Leonean War when she was 15 with her sister who was pregnant. And they were running away from the rebels who were approaching. And she said her sister was turned. And they ran and ran and ran. And at some point, her sister went into labor in the jungle, right? And delivered this baby. She had to take care of the baby, but she didn't know what else was going on. Her sister bled to death,
Mm.
and she had to keep running with the baby till she ran into 8 workers that helped her. So fast forward 15 years later, she comes to see me. She's 30, 31, and we just started to talk. And she told me that this baby she raised as if it was her own, and she never told her niece that indeed I'm actually your aunt, not your mother, and this is what happened to your mother. And she
Mm.
was able, when I started talking to her and all that story came out, I asked her to seek guidance and counseling so that she could heal from that trauma and go back to her niece and actually tell her niece what happened. They have a better relationship. But it was at that moment of her being able to heal that she got pregnant on her own.
Oof, that is so powerful.
Yeah.
Thank you for sharing. And I think those of us who've been doing this a long time, and especially those of us who identify as being fairly empathetic, we feel the energy, right? We feel the
Yeah.
energy in the room when we're doing a transfer, as we're having our consults. And sometimes we can truly feel these blocks that people have.
Yes.
And that's where the healing comes in. That's where we say, okay, how can we heal that, help them heal that part? How can we get the energy to move and then shift if it's stagnant? And I do think these traumatic experiences that we've had do create these blocks. Even previous negative, bad results,
Right.
bad news from the fertility journey can even create energetic blocks. And so
Right.
that's a very powerful story that you shared of of somebody who did have a big trauma, big T trauma
Yeah.
in their life,
Yeah. Yeah.
who was able
Yeah.
to move beyond that through
Yeah.
you and basically conceive herself, which is so beautiful. Wow.
Yeah. Yeah.
Well, I
Yeah.
cannot wait to read this book. I am so inspired by you. Is there anything
Thank
else
you.
that you'd like to share with our listeners before we sort of ask people, show people where to find you?
Yes. So I think that when you're thinking of fertility or when you're thinking you might be interested in conceiving in the future, you need to start preparing your body. You need to start looking at what can I be doing, eating, exposing my body to that may impact my fertility down the road. I think most people have this superhuman mentality, not thinking that what they're doing now can have an incredible impact when they finally decide they want to have children 10, 15 years from now. Now is the time to take care of your body, the you that's going to be the you that gives you that possibility in the future.
Oh, that's so beautiful. And for so many reasons, right? So we know that, I mean, as women, we're born with all the eggs we'll ever have. And so
Right.
our eggs are like the body we have
That's
now, our
right.
eggs are sitting in that body. And so
That's right. So
the
whatever
things
you
we,
expose it to,
yeah,
yeah,
that's
yeah.
amazing. Well, thank you so much for everything that you do for women, for couples, for everyone who's lucky enough to enter
Thank
your
you.
world. Your impact is just so profound. And thank you for taking your time to share your wisdom with my listeners. Yeah. So with that, where can people find you? Hello.
Yeah,
Hello.
it froze
It's
again.
it's okay. It's okay. So Dr. Yemi, where can people find you?
You can find me at montgomeryfertilitycenter.com. All one word, montgomeryfertilitycenter.com. And you can see all the links to all my social media on that.
That's amazing. So do you do telehealth consultations for people?
I do. I actually do. So we do virtual consultations first, and then, later on bring the patients in where I now see them, examining them, and go into more detail. So we always try to start. I mean, of course, if patients don't want that and they want to come in, we do see them, but we do
Yeah.
telehealth as well.
Well, I'm just thinking like if somebody's at an impasse and what they said here resonated and they want your perspective on their situation, go find Dr. Yemi. She's amazing. Listen to her podcast. And to my listeners, my dear listeners, you know how much I love you. Thanks, Dr. Yemi, for being here. Till the next time. Bye.